So thanks, Chris Chan, for the kind introduction. It's my real honor to be the first speaker of this special session at the 2020 FastCog meeting. So although COVID-19 is an infectious disease affecting mainly the respiratory system, it is also very relevant to FastCog. Because findings from the Open Safely database in UK, just published in Nature, show that among the 21 factors analyzed with respect to COVID-related mortality, patients with pre-existing dementia or stroke had an increased risk of death with a hazard ratio of 2.16. It's ranked number 6 among other variables, with age as the strongest predictor with a hazard ratio of 20 for those older than 80 years versus those who were 50 to 60 years of age. Age is followed by other conditions, mostly associated with impaired immune function, such as those who have received organ transplant or those suffering from hematological malignancy. So as a response to this serious threat to COVID upon older patients with dementia or stroke, I was very privileged to be able to coordinate among 34 distinguished dementia experts around the world from 30 universities and 17 countries. And many of them are closely connected with FastCog, as well as connected to ASAP, the Asian Society Against Dementia, where Chris is currently the president. So we put up a review focusing on 4 aspects. First, why dementia patients are having a higher mortality with COVID. Second, what are the potential biological impacts of COVID upon the brain? Third, there are potential adverse impacts of potential public health interventions that we have described in this review. And last, strategies that we proposed that could mitigate these adverse impacts and which can be of use in regions with ongoing outbreaks or for future outbreaks. You can find the details of this review at the Alzheimer's and Dementia Journal published last month. So first, the hypothesis we put forward explaining why dementia patients have high mortality can be divided into non-biological and biological. First, for the non-biological, dementia and stroke patients may be exposed to high viral load because physical distancing is not feasible to them, as they are dependent on others for support or for caring for their basic needs. And they are also unable to comply with various infection control measures, such as wearing surgical masks or frequent washing of hands. Second, majority of these dementia patients were probably living at care homes where there was severe spread of the infection. So this cohort effect might explain why dementia and stroke patients suffered from high mortality. And last, dementia or stroke patients might receive low priority in receiving intensive care unit support, in particular when hospitals were overwhelmed and personal protective equipment were inadequate. We also hypothesized that there could be some biological reasons explaining the high mortality. Since dementia patients are associated with dysregulated immune response, which both occurring in the brain as well as in the peripheral circulation to start with. So they are not able to mount an effective immune response to COVID-19. So the dysregulated immune function may include an increased baseline inflammation with increase in various cytokines such as interleukin-6, TNF, and TGF, commonly found in dementia or Alzheimer's disease patients. And this could probably precipitate an exaggerated immunological response to COVID infection. Another possible explanation is that many ApoE4 homozygous carriers was found to predict severe COVID-19 as well, possibly because among the many functions of ApoE4, one of them is to increase macrophage production of cytokines, including interleukin-6 or TNF, in response to pro-inflammatory stimuli. Hence, for dementia patients who were ApoE4 carriers, they are again having an increase in baseline inflammation, precipitating them to have an exaggerated immune response to COVID. Apart from the fact that dementia or stroke patients had more severe COVID, COVID infection itself may also have a negative impact upon the brain. And early case studies show that among severe cases, about 15% were found to develop encephalopathy or confusion, delirium, and or residual cognitive impairment. And about 6% of severe cases also had stroke, which include large or small vessel occlusion, hemorrhagic stroke, as well as venous thrombosis. And on this aspect, I would like to draw your attention to this recent review published in Cell by our vascular friend, Professor Constantino Iadocola from Weill Cornell Medicine in New York. An excellent review on the biological impact of COVID-19 on the nervous system. So the causes of encephalopathy may include indirect effects to hypoxia, sedating drugs, or even silent stroke, and rarely even to a post-ictal state after a seizure. It could also be due to neuroinflammation, where the cytokines in the peripheral blood crossing a leaking blood-brain barrier, leading to cytokine sickness, delirium, or even to intracranial cytokine storm. And the case of necrotizing hemorrhagic encephalitis was reported. Alas, there could also be this possibility of neural invasion, where virus infecting the endothelium or leukocytes infected with the virus, a Trojan horse mechanism, can cross a leaking blood-brain barrier and infect neurons. In case of COVID-related encephalitis was again reported. Though fortunately, presence of SARS-CoV-2 virus was not frequently found so far in cases of COVID infection. As for the reason explaining more severe stroke among COVID-19, it could be due to the prothrombotic state found in COVID infection, or endothelitis, as well as thrombocytopenia, which could lead to hemorrhagic stroke. So COVID-19 increases mortality in those with dementia or stroke, and it also increases the risk of encephalopathy and stroke among severe cases. Therefore, implementation of physical distancing, staying at home, are particularly important to this group of patients. However, these measures may also associate with other major adverse impacts. For those dementia or stroke patients living at care homes, banning of visitors will reduce emotional support and many group activities that are beneficial to the brain and cardiovascular health were suspended. And for those living at home with informal caregivers, many of the services that they have been receiving, such as help in household chores, care for basic needs, or activities that they have been attending at community or daycare centers, have also been suspended. And moreover, they are less inclined to seek help from doctors, resulting in possible decline in the health condition or occurrence of more medical events, including stroke or even myocardial infarction. And many patients will have increased in behavioral problems, depression or agitation with a prolonged confinement at home. And caregiver burden may also increase significantly during these times. And for those older patients with dementia or stroke admitted to hospitals, they are also more prone to develop delirium because of lack of support from friends and relatives. And the best medical care is hard to be delivered by healthcare professionals, including nurses or rehabilitation by therapists, because of the need of a physical distancing. So because of this potential adverse impacts, we have come up with strategies aiming to mitigate these adverse impacts associated with the various public health interventions at different settings, at care homes, at homes, and also in hospitals. And the details of it can also be found at the publication that I mentioned earlier. In particular, we have come up with a conceptual framework for home-based care that can be summarized using this 8Cs. It will be ideal if we can have a case manager who can coordinate various care aspects, including control of infection, care for basic needs, including wound care or care, a shower or other things, basic things, or giving advice of how to calm down challenging behavior problems, and how to maintain a comprehensive, multi-domain lifestyle even at home, and to ensure how that optimal clinical management can still be delivered via telemedicine for the cognitive and medical problems of patients, and also have concerns and give credits to caregivers at home. And last, we also advocate the use of telehealth or telemedicine to connect them with tele-technology amid COVID. So in conclusion, as the pandemic continues to evolve around the world, it is uncertain whether COVID-19 may change the demographics or even the dementia incidence or prevalence of our societies. Well, I would like to give a special acknowledgement to the 4 core members of this review. First to Philip Sheltons, the last author from Amsterdam, Netherlands. To Sarah Penderbury, second author from Oxford in UK. To Sandra Black in Toronto, Canada. And last to my close colleague and friend, Adrian Wong from Hong Kong. And also thanks, Chris, for chairing this session. And here's the Merlion from Singapore. And great thanks to Raj Kalaria from Newcastle, John O'Brien, and Hugh Marcus, all good friends from Cambridge. And thanks for hosting this wonderful FESCOG. And I'm sure, as in past conference, with great science, that this first virtual FESCOG 2020 will be a great success. And last, may I wish all of you great health amid COVID-19. Thank you for your kind attention. Goodbye.